Hello and welcome to the lecture on diseases of the myocardium. The objectives for this lecture are as follows. Differentiate the forms of cardiomyopathy. Apply pharmacologic and non-pharmacologic therapy used to restore balance in the hemodynamic variables. And finally, understand the pathophysiology, manifestations, and management of myocarditis. In the Diseases of the Pericardium lecture, we looked at conditions associated with the parietal and visceral pericardium. In this lecture, we'll move a little deeper and look at conditions of the myocardium. Most forms of cardiomyopathy are the result of remodeling secondary to neurohormonal responses to myocardial insult. There are a variety of etiologies, but there are two major forms of hypertrophy in these cases. These two forms are pressure overload and volume overload hypertrophy. Hopefully you can recall our discussion on the neurohormonal model. Remember that any insult can result in cardiac dysfunction, which produces decompensation. Decompensation presents as increased preload, increased afterload, decreased contractility, and ultimately decreased cardiac output. This may, in and of itself, trigger fluid overload, which is where you may see volume overload hypertrophy. Or, on the other hand, you may have neurohormonal activation, with increased renin-angiotensin-aldosterone system activity, increased catecholamines, as well as increased endothelin. This can produce chronic stress resulting in tissue remodeling, where you see pressure overload hypertrophy, or may produce renal vasoconstriction and fluid retention, contributing to volume overload hypertrophy. Let's begin by looking at dilated cardiomyopathy. Dilated cardiomyopathy is characterized by ventricular chamber enlargement and systolic dysfunction due to remodeling, with a greater left ventricular cavity size. Progressive dilation can lead to mitral and tricuspid regurgitation, which further diminishes cardiac output and increases end-systolic volumes and ventricular wall stress. This makes sense because your valves are supposed to close completely in order to prevent backflow. If you dilate the ventricle, you will in turn stretch out the valves, resulting in an opening where fluid can flow backwards. This is referred to as regurgitation. Where could you imagine this problem comes from? There must have been some form of insult to the myocardium resulting in volume overload. If you think back to the Frank-Starling law, when you stretch out the ventricle, you have an increased cardiac output. This can compensate for a decrease in cardiac output to a point. If you imagine you're stretching a rubber band, the further you stretch the rubber band, the more forceful it retracts. But you know you can't stretch the rubber band too far or it'll snap. Imagine the rubber band is actin and myosin. At some point, actin and myosin will no longer be in contact with each other, and you will not have a forceful contraction. Manifestations of dilated cardiomyopathy include dyspnea, fatigue, pulmonary congestion without pulmonary edema, chest pain, syncope or dizziness due to dysrhythmia, and an S3 and S4. An S3 indicates increased fluid. Here's what an S3 sounds like. An S4 indicates a stiff ventricle. And here's what an S4 sounds like. On the chest X-ray, The only thing you'll see with dilated cardiomyopathy is an enlarged cardiac silhouette. You'll notice that the heart size is greater than 50% of the total width of the lung fields. This is not a very specific finding, as it occurs in all cardiomyopathies as well as heart failure. On the other hand, on an echocardiogram, you'll notice a very dilated left ventricle. Here's a list of etiologies for dilated cardiomyopathy. Beside each condition, I've listed additional testing that may indicate that that's the underlying problem. The treatment for dilated cardiomyopathy includes the following. You'll want to decrease preload through sodium and fluid restriction as well as diuresis. You'll want to decrease afterload, and one way you can do this is through vasodilation through an ACE inhibitor such as captopril. You'll want to increase contractility, which can be done through dobutamine or digoxin. And you'll want to decrease workload on the heart by restricting activities. Oftentimes with these patients, you'll implement preventative measures for venous thromboemboli. So these patients may be started on anticoagulants. Patients with dilated cardiomyopathy may require pacing to improve cardiac output or even heart transplant. Some complications of dilated cardiomyopathy include pulmonary embolism and valvulopathy. Could you imagine how you would get a pulmonary embolus from this condition? If you stretch the heart and it reduces the ability of the heart muscle to contract, in the center of that fluid, blood will coagulate. And then, at the point where you have a forceful contraction, you'll release that clot into the circulation. Next, let's discuss hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, the ventricle is thickened by the process of hypertrophy. This is often a result of pressure overload. There are two major categories of this condition: hypertrophic obstructive cardiomyopathy, which consists of asymmetric septal hypertrophic cardiomyopathy or subaortic stenosis. And the second category is hypertensive or valvular hypertrophic cardiomyopathy. These differ in etiology, pathophysiology, and presentation. On the chest X-ray, you will notice an enlarged cardiac silhouette as well as left atrial enlargement. Why would this occur? Think back to normal blood flow. Blood normally comes through the pulmonary veins into the left atrium, which then moves through the mitral valve to the left ventricle. If the left ventricle is thickened to the point that the chamber size is reduced, blood will back up into the left atrium. On the echocardiogram, you will see the hypertrophied left ventricle. The actual chamber is anechoic, meaning that the area will be very dark. This is due to the presence of blood. You can see the thick ventricle surrounding this chamber. Obstructive HCM is a common inherited heart defect. This is characterized by thickening of the septal wall, which may cause outflow obstruction to the left ventricle outflow tract. This results in a hyperdynamic state with impaired diastole and decreased ventricular compliance. Manifestations may include chest pain, syncope, palpitations, symptoms of a myocardial infarction or left heart failure, extra heart sounds or murmurs, dysrhythmias such as atrial fibrillation due to enlargement of the atrium, PVCs, or bursts of ventricular tachycardia. Management of obstructive HCM includes decreasing afterload through the use of beta blockers or verapamil, surgical resection, septal ablation, or prophylactic ICD placement. Complications of this condition may include ventricular arrhythmias and death. The heart chambers are very sensitive. If you stretch or distort the connection between the SA node, AV node, bundle branch, and or Purkinje fibers, arrhythmia will result. Hypertensive or valvular HCM occurs because of increased resistance to ventricular ejection associated with hypertension or valvular stenosis, and in this case it's usually aortic stenosis. Hypertrophy acts as a compensation for increased ventricular load. This condition is manifested by chest pain, syncope, dyspnea on exertion, palpitations, extra heart sounds, or murmurs. Management of hypertensive or valvular HCM involves targeting the underlying condition. Now let's discuss restrictive cardiomyopathy. Restrictive cardiomyopathy involves restricted filling and reduced diastolic volume of either or both ventricles with normal systolic function and wall thickness. This results in a rigid and non-compliant ventricle. This impedes ventricular filling and increases filling pressures during diastole. There aren't very many characteristic manifestations, but restrictive cardiomyopathy usually presents like right heart failure with systemic venous congestion, cardiomegaly, and also can present with dysrhythmias. One characteristic finding that you may see in restrictive cardiomyopathy is on the echocardiogram. Because you have stiff and rigid ventricles, you have bilateral ballooning of the atria. Restrictive cardiomyopathy may be a result of scleroderma, amyloidosis, sarcoidosis, lymphoma, hemochromatosis, or an inherited storage disease. Treatment is aimed at the underlying cause. The patient may require steroids for sarcoidosis, phlebotomy for hemochromatosis, chemotherapy for amyloidosis, and in general may require an ACE inhibitor, diuretic, a vasodilator, and anticoagulation. Complications of restrictive cardiomyopathy include death due to heart failure or dysrhythmias. In these patients, consideration for permanent pacing, a left ventricular assist device, or transplantation may be warranted. Now let's discuss our final myocardial disease, myocarditis. Myocarditis is inflammation of the myocardium. Inflammation always results in scar tissue formation, where there's interstitial collagen and elastin destruction. This condition can result in dilated or hypertrophic cardiomyopathy with varying degrees of hemodynamic alteration. Myocarditis may result in mural thrombosis, where there are thrombi on the heart wall, infiltration of circulating blood cells, degeneration of muscle fibers, and often cardiomyopathy and heart failure. The causes of myocarditis can fall into the category of infectious or immune, but can also be due to immunosuppressive therapy, endocarditis, Crohn's disease, or systemic lupus erythematosus. Myocarditis may be asymptomatic, but the patient may present with fatigue, dyspnea, syncope, palpitations, chest or abdominal pain, flu-like symptoms, symptoms of heart failure, or may experience sudden cardiac death. On physical examination, you may notice a faint S1, a ventricular gallop, or a systolic murmur. The cardiac cath on these patients will be normal, and you may see an elevated white blood cell count as well as an erythrocyte sedimentation rate. On the EKG, you'll really only see some nonspecific ST changes with sinus tachycardia. On the cardiac MRI, you may see these small areas of myocardial edema, shown here by the arrow. In terms of management of myocarditis, preventative measures may include immunization for hepatitis or influenza. Otherwise, you'll want to target the underlying cause, for instance, penicillin for streptococcal infection. You'll want to encourage bed rest to decrease cardiac workload, limit activity for 6 months, and increase activity slowly. Manage the symptoms of heart failure. Avoid NSAIDs because they're linked with worsening of inflammation in this particular condition. And it's also important to note that these patients have increased sensitivity to digitalis, so you'll want to monitor for that. And finally, venous thromboembolism prophylaxis is key in order to reduce the incidence of mural thrombi.